This is Dr. Chad Rappaport, and this presentation covers the general principles of deformity correction in total ankle arthroplasty. In this presentation, I'll briefly cover an introduction to deformity correction in total ankle arthroplasty, and then touch on the evaluation of the patient preoperatively, and then specifically discuss deformities proximal, within and distal to the ankle. We know that survivorship of total ankle arthroplasty depends quite heavily on establishing a well-balanced, well-aligned prosthesis. We also know, extrapolating from the total knee literature, that acceptable postoperative alignment is alignment within 3 degrees of neutral or the planned preoperative target. And total ankle arthroplasty certainly is no different. The demands on total ankles are at least, if not greater than total knee. And so 3 degrees to 5 degrees deviation is probably the maximal amount of acceptable deviation. In the coronal plane, which can obviously either be varus or valgus, years ago the extent of deviation from neutral in the coronal plane manageable with TAR was around 15 degrees, and that has risen to 30, if not more. There's significant literature out there showing that there quite possibly may be no maximal degree of coronal plane malalignment that can't be reduced to an acceptable limit with total ankle arthroplasty. And these deformities are generally considered to be congruent or incongruent or intra-articular or extra-articular. We'll talk about this more in a few minutes. Sagittal plane deformity, although less discussed in the literature, can exist as well, either independently or part of multiplanar malalignment, and also must be addressed successfully to ensure an acceptable outcome. With regards to coronal plane deformity, when the deformity is intra-articular, it generally refers to an incongruent joint, wherein the most superior aspect of the talar dome and the tibial plafond are not parallel and are therefore divergent. In these instances, correction is not achieved prototypically solely with the bone cuts, and these deformities typically require certain degrees of soft tissue balancing coupled with osteotomies or fusions within the foot. Extra-articular deformities are typically deformities that have a congruent tibio-talar joint, wherein the superior aspect of the talar dome and the tibial plafond are parallel or non-divergent. And these are more often the type of deformities that may be corrected solely through the planned bone cuts of the tibia and the talus. We've already established that accuracy in terms of reducing and eliminating these deformities and establishing a neutral alignment as much as possible are integral to the survivorship. But why? And the answer is that in an unbalanced malaligned prosthesis, you're going to have more potential episodes of instability. You're certainly going to have more edge loading of the prosthesis, which can lead to subluxation, subsidence, and overall failure of the prosthesis. So once again, survivorship is directly correlated with neutrality and a balanced prosthesis. When we're talking about deformity correction, one of the hot topics, if you will, is whether these can be corrected in one sitting, or are they better off addressed in a staged fashion. And certainly there's lots of factors that will go into deciding whether or not the procedure is done all in one sitting or staged, but the more important factors include operative time. We know that as operative time increases, so do the rate of postoperative complications, of wound healing issues, of infection, etc. Spacing of incisions. If you have to make multiple incisions about the ankle and the hind foot, this is something that certainly can affect the rate of postoperative complication. The vascularity of the bones, most notably the talus, needs to be considered when deciding whether to stage these procedures or do them all in one sitting. But with that said, and we'll touch on those more in a moment, more often than not, the varus deformity can be done in one sitting, whereas valgus deformities are not so easy to do in one sitting, although there are certainly proponents of doing this all in one sitting with regards to a valgus deformity. A patient who is a potential candidate for a total ankle certainly needs to be evaluated comprehensively, not from head to toe, but certainly from hip to toe, including a gait analysis, an evaluation of the limb in its entirety, and comparison of that evaluation to the contralateral limb, looking at deformities proximally within the hip and more notably within the knee. Questions such as, is the patient likely to undergo a total knee arthroplasty, which is a scenario which has unfolded itself many times in my practice. Certainly, we'll get into this a little bit more in a few minutes. If a patient is likely to undergo a total knee arthroplasty or has stiffness, pain, and malalignment of the knee, it's most likely beneficial for the patient to have that addressed before their total ankle. One has to look at range of motion of the knee, therefore, and of course the ankle and the foot, and determine whether or not any deformities within the aforementioned are reducible or rigid. This can obviously have an impact as to whether these deformities can be corrected with osteotomies and soft tissue balancing, or they are going to require arthrodesis. And arthrodesis within the foot, whether it's one joint or two joints, can certainly have an impact on whether or not the patient should be staged, or if the patient, if proceeding with total ankle arthroplasty, can be done in one sitting. Tools that we use in terms of imaging to help determine some of these things obviously include standing films of the ankle and the foot. Salzmann views are generally recommended, as are standing films of the knee for the aforementioned reasons. CT scan is essential, in my opinion, as well, and certainly with the advent of weight-bearing CT scans, this can give us more detailed information regarding the patient's deformity, particularly if it can include the knee. At the time of this presentation, the curved beam weight-bearing CT scan is the only one that can include the knee. But just in general, CT scans can give us more specific, detailed information about the alignment of the limb and the aforementioned joints, but probably most importantly, it can give us information with regards to the bone quality within the limb, which often cannot be seen or underestimated with plain films. Bone quality is paramount, obviously, in total ankle arthroplasty, and so the acknowledgement of cysts in the distal tibia or the talus is certainly something that's paramount to know before embarking on a total ankle arthroplasty. So the principles of establishing the CORA are paramount in planning for total ankle arthroplasty, and not to beat this to death, but this is vital because we know that deformity in total ankle arthroplasty is much more common and much more severe than it is in the knee, and this of course is due to the etiology, which in the ankle is much more likely to be post-traumatic than in the knee, where it's more prototypically primary osteoarthritis. And once again, the deformity can be proximal to the ankle in the hip, knee, or in the distal tibia. As a result of a distal tibial fracture, for example. The deformity can be intra-articular or it can be distal within the foot. And prototypically, when we're looking at the foot, you're looking at or dealing with deformities that create a valgus or a varus foot. Either patients that have progressive collapsing foot deformity with resultant medial instability, or pes cavus feet, wherein there's more prototypical lateral instability. And as mentioned a bit earlier, although a lot of the literature and discussion is more focused on the coronal plane, certainly one needs to appreciate any sagittal plane deformity, which is typically proximal to the ankle joint in the way of a procurvatum or recurvatum deformity within the leg, or intra-articular deformity secondary to plafond erosion anteriorly, or posterior malleolar deformity and insufficiency. Identifying and correcting deformity proximal to the ankle joint is imperative because many times, if not most times, these malalignments can have a greater impact on the ankle than those that are distal due to the lever arm. Additionally, if there's malalignment or deformity more proximal, this may skew some of the anatomic reference points that we often utilize depending on the system that's being employed for preoperative planning with regards to total ankle arthroplasty. Lastly, if the ankle is done before the hip or the knee, the correction of the deformity in these more proximal locations may have derogatory effects on the mechanics of the ankle. And therefore, once again, correction of these deformities proximal prior to performing total ankle arthroplasty is recommended. Distal to the hip and the knee, but still proximal to the ankle, would be deformity within the tibia itself, which can be developmental, it can be congenital, but most often in our practices is post-traumatic. And although coronal plane deformity within the tibia obviously is possible, more often than not, we're talking about sagittal plane deformity with either the apex being anterior or posterior. And generally, the more concerning deformities are within the distal 1/3 of the tibia, where the effects distally or more on the ankle are more profound than deformities in the proximal 2/3 of the tibia. More often than not, this is a recurvatum or anterior apex deformity, which can cause the so-called spitting talus deformity. So deformities proximal to the ankle, specifically in the hip and the knee, can be corrected with femoral or proximal tibial osteotomies. More often than not, these are corrected with total hip or total knee arthroplasty. With regards to the distal tibia, malalignment is generally corrected via an osteotomy, which can be a closing or opening wedge osteotomy, a dome osteotomy or a correction that's done via distraction osteogenesis. Addressing deformity distally within the foot is obviously imperative. As we know, we can't implant a prosthesis on top of a malaligned foot, or it is doomed to failure. And the deformity within the foot can either be the cause of the deformity within the ankle or a compensation for deformity within the ankle or above it. So it's important to identify a planus or a cavus deformity. It's equally as important to identify the deformity as being supple or rigid, and once again, therefore, being amenable to soft tissue balancing and osteotomies versus fusions. Deformity can lead to either laxity medially or laterally of the ankle, which of course needs to be addressed. Generally, the foot will follow the talus, so a valgus ankle will be more consistently seen in association with a pes planus or valgus foot, whereas a varus ankle is more prototypically encountered with a pes cavus or varus foot. However, one needs to be cognizant of the possibility of the so-called ping-pong deformity of the ankle, wherein the deformity in the ankle is opposite of the deformity within the foot. Once we've identified deformities distal to the ankle within the foot, especially when they're flexible, these may be addressed in the same exact way as they would be in a patient who doesn't require a total ankle arthroplasty. Recognizing arthritic joints in the hind foot is particularly important. And in joints that are mildly or moderately arthritic without deformity, we know that these joints may not need to be fused, because when the ankle arthritis is addressed with the prosthesis, many of these patients become asymptomatic in the adjacent joints, particularly the subtalar joint, once the arthroplasty has been performed. So once again, one needs to be comfortable with either doing this all in one setting or staging it. There's multiple factors that go into this decision, and this is something that will vary from one surgeon to the next, particularly as one gains experience and confidence in doing these procedures. Vascular risk, especially to the talus, in the setting of a patient who requires a arthrodesis, either a TNJ or a subtalar joint, and a total ankle. There's many who are steadfast against doing these procedures at the same time due to the potential vascular insult to the talus and the therefore resultant risk of AVN and subsequent subsidence of the talar component following the total ankle arthroplasty. How many incisions are you going to have to make if you're creating multiple incisions adjacent to one another in and around the ankle and the hind foot? It may be more prudent to stage these procedures. One must look at the presence of existing hardware, which is much more common in total ankle arthroplasty than in knee and hip arthroplasty due to the post-traumatic nature of these patients. We've all had cases where we thought taking the hardware out would be a 20-minute endeavor, and before we turn around, we're an hour and a half into the procedure and still have multiple screws or plates to take out. So this is a big factor that should go into considering whether to do these staged or all at the same time. And all these kind of fold into operative time. We know that as the operative time increases, the complication rate following total ankle arthroplasty increases. Generally, although there's proponents of doing the ankle first and then the foot, I think generally speaking, it is more accepted to do the foot initially and then the ankle. Doing this allows the surgeon at the time of the arthroplasty to fine-tune, optimize, or tweak the foot if need be. Once the foot has been corrected or neutralized, it has been recommended and published in the literature to use cement or a screw within the confines of the ankle joint to keep it in neutral or as neutral as possible as the foot heals before embarking on the total ankle arthroplasty. And at the time of the arthroplasty, the cement or the screw is removed, and at this point you have a more straightforward procedure with likely reduced operative time and less insult to the foot and the ankle. And again, at this point in time, you may optimize or fine-tune the foot as need be. So generally speaking, procedures that can be done at the same time in one sitting as the total ankle arthroplasty seem to be osteotomies of the calcaneus, certainly different types and forms of soft tissue balancing, and generally one arthrodesis of the hindfoot. But as mentioned previously, there is continual debate as to whether or not, if the arthrodesis is the subtalar joint, whether this should be staged and done prior to the total ankle, or it can be safely done at the same time as the total ankle. If it is done at the same time as the total ankle, it's highly recommended to prepare and fuse only the posterior facet and try to salvage or save the vascular elements within the sinus tarsi. Generally, two stages are required if one needs to perform multiple fusions, if there's going to be multiple incisions, lots of hardware to remove, osteotomies proximal to the ankle joint. But again, this depends heavily on the level of comfort that the surgeon has and their experience. Certainly, some of the more seasoned arthroplasty surgeons may be comfortable doing multiple procedures at the same time as the ankle, wherein surgeons just starting out in total ankle arthroplasty certainly would and should be more comfortable doing these in a staged fashion. I apologize, these slides are in incorrect chronological order, but an example of what we're talking about is the slide in the middle, which is a patient that presented to me with this rather obvious and significant intra-articular valgus deformity of the ankle with associated deformity within the foot. I deemed it necessary to perform a subtalar joint arthrodesis in this patient, and so in my hands this was staged. And you can see on the far right, this is what it looked like after we corrected the foot. I put a transarticular screw in place and obviously kept this patient non-weight bearing as his foot healed and as he awaited his total ankle. This is actually a fluoroscopy image of me identifying the tip of his screw right before we embarked on his total ankle, wherein I removed his subtalar joint fixation screws. And then if you look to the far left, this is his final product with an in-bone 2 and a prophylactic medial malleolar screw. This is another quick example of, I think, my second or third total ankle that I did. And this was and still is a scenario that I would choose to do in a staged fashion. We all have taken hardware out in cases like this, and this can be a fairly quick, straightforward, easy procedure, or it can be a nightmare. And if it turns out being a nightmare, you certainly don't want to do this at the same time as a total ankle, because this could chew up an hour and a half, who knows how much operative time. And again, it gets to the point where you're really rolling a dice trying to do the total ankle at the same time. In summary, total ankle arthroplasty in the face of deformity is certainly challenging. Most times it's more complex than total knee and total hip arthroplasty due to the etiology, which is post-traumatic, which means that many of these patients have deformity that our total hip and total knee colleagues don't see nearly as frequently. And this, of course, subsequently means that many of these patients have retained hardware that requires removal. These patients have had prior surgeries with prior incisions. That, coupled with the fact that we're dealing with an unforgiving soft tissue envelope, means that we need to be careful about correcting these deformities, but doing them in a way that doesn't risk the ultimate survivorship of the total ankle. If you're going to do these cases, you must be able to address the deformities and the potential complications that may arise with correcting these. And inexperienced surgeons should stick initially to straightforward cases initially and use resources available to you. Of course, read as much as you can read. With the advent of things like ViewMedi and Foot Innovate, watch as much as you can watch, and scrub in, when feasible, these cases with surgeons that are more experienced than you. Additionally, there's things that exist like Ask the Expert from Right/Stryker, wherein you can present your case to an expert who will either over the phone or via Zoom walk you through a case and help you determine what collection of procedures you need to perform and whether or not these should be staged or it's possible or feasible to do these in one setting. So there's lots of resources out there available. You should use them. This is not meant to be an intensive review of all potential deformities and all the potential procedures utilized to correct them, but more so just a general overview of the types of deformities and how you might go about addressing them. I hope this helped. Thanks for watching.